joining today's session in the Connecting Our Community Special Needs Speaker Series. As the title indicates, our goal is to connect resources with the special needs and disability community. This series is offered on the fourth Wednesday of every month from 11:45 a.m. to 12:30 p.m. Eastern Time. And many of you may know that I am both a parent and a professional dedicated to serving the special needs community. Throughout this series, we are speaking with experts in many fields relevant to this community. Last month, we spoke with Chuck O'Neill of Executive Services about the importance of planning. I am always open to suggestions for additional resources or topics about which you would like to learn. Today, we have the pleasure of speaking with Dr. John Harris. Dr. Harris is an assistant professor of ObGyn at UPMC Magee Women's Hospital. He specializes in care for women with disabilities and is the director of Center for Women with Disabilities at Magee. The center was founded 22 years ago by Sandra Wellner and provides women's healthcare services to people with disabilities. These include intellectual, mobility, or sensory disabilities, from adolescence to end of life. Outside of his clinical work, he is a researcher funded by the National Institutes of Health and the Pennsylvania Department of Health on the relationship between disability and obesity, as well as the relationship between disability and reproductive health. He lives in Pittsburgh with his wife, Sarah Jo, and their 5 sons. Dr. Harris, thank you very much for joining us.
Thanks for having me, Christine.
And I am just going to pause a moment. We have a few more people joining us through the waiting room, so I'd like to have them join before we really dig into things here. I will try to keep up with anyone else that joins us as we come along here. But as we get started, I know that regular healthcare is important for all women, and we will discuss some of the barriers to women with different disabilities. But to get started, Doctor, what do the numbers tell us about women with disabilities receiving appropriate care?
Oh, that's a great question. So unfortunately, we know that there are some disparities where women with disabilities, whether those are intellectual or mobility, that's where most of the research is in those 2 areas, that they're less likely to receive certain services related to women's healthcare. So the most common ones there would be Pap smears, so screening for cervical cancer, as well as screening for breast cancer. Both of those are less likely in those populations. There's some other areas such as screening for sexual abuse and other things that are probably also lower than in the general population.
Thank you for getting us started with that, because I do think that it is pertinent to know that the numbers are disproportionate. But there also seem to be a lot of myths around whether women's care is necessary for these individuals that we're discussing. So please, as we discuss different areas, I'd ask that you address some of those myths. But let us start with, what are some of the possible barriers to receiving women's health care for someone that has a mobility disability?
Well, there are many types of barriers. So one of those barriers may be in just getting basic care in the clinic office that they choose. So for someone with a mobility disability, we want to make sure that they have an accessible office, an accessible exam room, an accessible exam table. And that's a complicated question, just because accessibility may mean the ability for the person to self-transfer over to that bed comfortably without feeling like they're at risk for falling off, as well as if they need help with assistance, that they have whatever help that they need to do that. For instance, in our clinic, we have a Hoyer lift, so we can do that safely, safe for our staff, safe for the patient. Other things like having a scale that allows us to weigh someone in their wheelchair, then we'll transfer them to the bed. We can weigh their wheelchair alone and know what their weight is, making sure that there's a bathroom that's accessible for people. Those are just some of the many ways that it's important to provide just physical accessibility. And that can go on to thinking about how mammograms are accessible for people, a variety of different things. And then making sure that the providers are comfortable with how maybe you should think through the exams, the problems that could be related to things for people that have whatever condition that might be associated with that disability.
So as we consider some of those accommodations or just considerations, in all honesty, we also can look at what may be keeping some women from care. But I think it's important. Can you mention what are some of the common women's health issues that should be addressed specifically for someone with a mobility disability?
Well, that's a great question. I would think through talking about abnormal periods, about cervical cancer screening, about breast cancer screening, about discussing about for someone with a mobility disability, their desires for parenting or pregnancy, talking about related to that, talking about contraception or problems with sex, questions about sex, things screening for sexually transmitted infections or sexual abuse. And the list could kind of go on from there, but certainly that's a good starting place. And these are all things that may be kind of low on the list of discussing with their PCP because maybe there's other things going on and people just don't get to these important issues.
Right, right. Well, and as we talk about this, let's also consider, what about women in larger bodies? Does your clinic provide weight-inclusive care?
That's a great question. Unfortunately, people of all different body sizes may develop a disability, and we do know that there are also disparities for people with overweight and obesity at all different levels that may be affected by these things. And so we want to provide really inclusive care for everybody and every type of body, and that may mean having equipment that helps people be comfortable in an exam. And so that's a really important thing for us because we do feel like this is very consistent with our goal of providing accessible care for people of all, regardless of how their body works, looks, or feels.
Absolutely. And I'm going to jump into something that, I am hopeful that we all teach our daughters to protect their bodies. And I imagine that lack of understanding could be a possible barrier to receiving women's health care, especially for someone with an intellectual disability. So how do you address this, and what other barriers do you encounter for women with intellectual disabilities?
There are a lot of unique challenges. So, the first one is thinking about their risk for having issues, I guess, need a women's health doctor. So for some people, their caregivers, family members, a person with intellectual disability, and they may say, well, this person, they live in a safe environment, they're not sexually active, they're not having problems. I don't think that there's any real need to see a GYN doctor. Furthermore, if they were to see one, they wouldn't be able to understand what's going on. The exam could be very traumatic and uncomfortable, and it wouldn't even be effective, maybe because of the shape of someone's body, the limitations of their mobility of their hips, a variety of different things. And so they're sort of addressing things in a clear and understandable way. I would say that, one of the basics, I think, limitations for a lot of people is that many women's health doctors see patients very quickly with very short appointments, which I would say is inappropriate and not accommodating for many women with a intellectual disability that do need longer to kind of get to know someone, to feel comfortable. Clearly, you want to have a trusted individual there with you. And so there's kind of many steps to it, but we both want to provide accessibility, but then also encourage people that we want to provide the standard of care that this person's sister or cousin or mother or anyone else would receive during their healthcare. And unfortunately, this individual is also at risk for a variety of different challenges that may not be addressed by another doctor.
Well, I think what you had just said there about providing the same standard of care that other women are receiving is crucial to this. And we've touched on a number of the barriers, whether it be for mobility, body size, or intellectual disability. But let's also touch on some of the myths around this, because there may be people hearing this saying, that's great that you know what the challenges are, but why am I going to battle those challenges? I don't need to do that. So can you touch a little bit on some of the myths around it?
Sure. One myth is that that managing periods may have kind of a limited benefit to someone who never reports any issues with their periods. And so, the first thing I often address is trying to understand whether there's any relationships with behaviors, challenging caregiving situations, anything like that related to their menstrual cycle. And so if there is, there may be real benefits for that individual and their quality of life, as well as for the caregiver and their quality of life, to thinking about ways of adjusting or altering those menstrual cycles so that people's lives are more consistent, so that they're more comfortable in their bodies throughout the month, and just so that they don't have maybe some of the unique challenges that would be described as like premenstrual syndrome in other populations. There's a more severe version of that that's basically like very deep behavior changes or depression called PMDD that we often address and treat. So thinking about that, thinking about issues that may be under addressed. So by screening for cervical cancer, we also sometimes uncover unknown infections that could be related to sexual contact in the past. And so while we can't always understand what happened or find the perpetrator, we can prevent complications from these horrific things that do happen. And so the only way to know about that is to screen people for the things that other women would be screened also at the same intervals throughout their lifetime.
So I think that part of what you're getting at there, if we're thinking, well, this is a population that may not be sexually active, why do they need to go to the doctor? You're bringing up some very clear points about why all women should go to the doctor and receive women's health care. And I think that some of the things that you just discussed there about menstrual periods, and what are some of the possible benefits then of medical management of those periods?
So for people that have very severe, disorienting, very disruptive changes in their behavior during, before, immediately after their periods, we can space people's periods out so that they're less often, so they stop entirely. There's numerous ways that we can hopefully improve people's quality of life, simplify behavioral management for people with intellectual disability, sometimes simplify hygiene for people that hygiene's a real issue around their periods. So things like that we want to help, improve. In most cases, I'm providing these medications for their menstrual suppression or modification effects. These are the same medicines that are used often as contraception, but these medicines I'm providing are for improving someone's quality of life. They're not for the purposes of contraception. Many of these people could not assent or consent to sex and need to be in safe places where they would never be at risk for unwanted sexual contact and pregnancy. So my main goal is assuming safety in an environment is to improve quality of life.
Well, and the quality of life is so important. And, you and I discussed this. This is not about the quality of life for a caregiver, but in all honesty, if we've improved the quality of life for any woman, we probably have improved the quality of life for those surrounding her, right?
Certainly. I think that, a patient exists as a team with their caregivers. And, I respect and want to listen to all perspectives about someone's care. There are times when, we have to find a balance between everyone's needs and desires. But I do think of it as a team where you do want to kind of ask everybody about what's going on and what's most challenging from the patient's perspective, from the caregiver's perspective. And there might be like a really, helpful solution that is able to generate both benefits, for the caregiver and for patient.
Absolutely. So just pivoting a little bit, because we focus specifically in a couple areas, pardon me, but what about women that may have sensory disabilities?
That is a great question. People with sensory disabilities, of course, they may be coexisting with another intellectual disability or a mobility disability, but sensory disabilities like hard of hearing or deafness, vision impairment, or blindness are very important to me, because usually that means that there may be a greater challenge of communicating and providing adequate education when appropriate. And so a good example of that is if someone comes in and I counsel them about a medication or about a medical condition, I want to make sure that I'm providing resources that will help this person, remember these things. And so doing things like audio recordings, many people's phones now have an audio recorder basically built in. So I can record the things so that it's not just a one-time verbal thing for someone to say that it is blind or vision impaired. They can go back and replay that and be like, what did John say about everything? For people with hearing impairment, our clinic will provide an ASL interpreter. That would be a in-person one. If we're, have heads up and we know about that beforehand. If it was someone that came in with an acute need, we can use a video service for anyone that was, needed that service like acutely. But we do want to provide as many accessible technologies as well as ways to remember information as possible. There's some really interesting information all around how sensory disabilities alone affect women's healthcare. Just to make an interesting example is that for someone that has deafness or hard of hearing and doesn't have any other medical condition, that there's research that we've participated with some of the researchers in other universities and cities that have shown that women in pregnancy with deaf or hard of hearing actually have more pregnancy complications. And knowing that they have the same medical conditions and risks, why do they have more complications? It may just be because it's harder to report symptoms of pregnancy or preterm labor or things that are bothering them. And they just tend to say, oh, I'll just wait till the next visit because it's harder to call the nurse line or something like that. And so it's amazing how sensitive healthcare is to slight changes in communication.
That is pretty impressive. And, communication is so important in all aspects of life. But when you get into situations where there's a sensory disability that complicates that communication, it does sound like it's a very crucial point to consider that it may get in the way of the proper healthcare. So I appreciate you pointing those things out. One of the things I want to kind of flip back to, because you mentioned it kind of as we talked about some of the other things, but can you talk specifically about sexual abuse among the disability population?
Yes. So unfortunately, people with physical and intellectual disabilities are at a higher risk for sexual misconduct, abuse, and things called reproductive coercion, where people are controlled about their decisions about, say, contraception, things like that, in higher rates than other populations. So in the general population, the rate of reporting sexual abuse in some form is often quoted around 6%. That's unfortunately horrifically high, but in the disability population, it's often doubled. So about 1 in 10 people will often report some element of sexual abuse. In the intellectual disability community, that rate is also still very high. I would say that among my patient population, where I see several hundred women a year for general women's healthcare services, that we diagnose 2 or 3 people a year that have an intellectual disability, could not consent or assent for sex. These are people with what we would describe as a severe intellectual disability who will come back positive for a sexually transmitted infection. And this is a real travesty. I wish that I could say that I could be some part of helping with justice. Certainly we report that, we help their residential setting, their family, to understand the meaning of it. We can't tell people when some said action happened or kind of directly point towards a perpetrator. But this is the first step. I always say that by reporting this, by helping people understand that there's been some sort of sexual contact in the past, that it may help people to reinterpret, other staffing issues in the past, questionable behavior that wasn't, that couldn't quite be kind of pinned down about what was going on. There's a lot of different ways that we can kind of look through that. Certainly in our perspective, when we find sexually transmitted infections, we screen for other ones. We try to prevent complications like abnormal pap smears that are sometimes related to sexual contact. And we just try to understand, the physical, mental, caregiving implications of abuse in this setting.
Well, and I do think you touch on so many things there that really are probably top of mind for a lot of caregivers. And when we look at these situations, I think it just brings to the foreground the importance of pursuing the healthcare. I am curious though, age-wise, what do you tend to see age-wise in your clinic? What's the age of a patient?
So our patients vary from probably around 15 to I'd say 95. I'm sure that we've had a few people a little older than that. So, I'm going to care for people as they're transitioning out of pediatric care, someone with an intellectual disability or physical disability who'd like to transition to an adult provider. I'll see those patients. And then I also see a lot of patients from nursing homes that have a physical disability, dementia, and need a care setting that's going to be effective and helpful for them in where they're at in their lives. So it's the very, very broad definition of women's healthcare. And we also provide surgical services as well as general care. We even are providing what we call pregnancy support consults for people during pregnancy that need a little bit of extra integration of how pregnancy is interacting with their disability, the conditions related to their disability, and trying to improve kind of caring for the whole person.
Interesting. Now, because you mentioned that you might be treating women who are senior citizens, what are some of the common concerns for someone that is older?
It's a great question. The first thing I always say is that there are so many people out there are so conscientious about their health that they come in and they'll see me and they'll say, I haven't seen a GYN doctor in years and I'm so sorry and apologetic. And I always say, there's no need to apologize. As people grow older, we are a little bit more of an as needed doctor. I mean, I want people to be getting cervical cancer screening, getting breast cancer screening, getting colon cancer screening, but that's going to be done by many other doctors. So things that we should see people for if they're getting good preventive healthcare through another provider would be things like postmenopausal bleeding. That's always a reason to see a doctor, whether this is, you're a caregiver for someone with intellectual disability and they're having bleeding, but they haven't had bleeding for years. We need to see those patients. We do diagnose cancer regularly in these populations, as well as managing things like abnormal skin conditions of the external genitalia. So as we all grow older, we all have different skin conditions that we feel like we notice in all of our skin. And unfortunately, it affects everybody's skin everywhere. And so symptoms of burning or itching, you may have a patient that seems like they've started, rubbing in a place that they didn't used to, and we don't know what's going on. We're happy to see those patients and evaluate them for a variety of skin conditions that are treatable, but can easily be mistaken for some other kind of a little bit more, let's say routine, not medical issue.
Interesting. But it does tell you that, Grammy should still go to the doctor.
Yes, but they should. I want to encourage people. They don't need to feel guilty about not seeing me, but I would love to see people when they have an issue or they have a question.
Sure.
And happy to help.
Sure. Makes sense. It really does. So just kind of going back to some of the things that we talked about with the different disabilities, I'd like to discuss more some of the accommodations. So we talked a little bit about someone with a mobility disability, some of the specific needs, whether, they be just in general getting somewhere or unique to seeing someone who's an OBGYN. But how about, again, those people that may have intellectual disabilities? What kind of accommodations can you offer for those people?
That's a great question. First I would say that accommodations start from the front door. We want to, in our setting, we have valet services. So if someone comes up in an access van or, another type of that, it's easy to get in the front door. People know where the clinic is. Our clinic has a really large waiting room. There's interesting literature around caregivers for people with intellectual disability often being uncomfortable in really small, tight waiting rooms, just because maybe you can't control the vocalizations of your loved one or caregivee. And so having a nice large waiting room is helpful just to give people space to be comfortable. Our nurse and medical assistants are experienced in interacting with people with intellectual disability, with autism spectrum, whatever situation. And we do have longer appointments so that we can get to know people. Additionally, there may be a variety of unique positions that different patients might be more comfortable in that we can complete an exam. It doesn't have to be the kind of classic exam position that many people will associate with GYN care. There's a variety of modifications that may work better for different people.
Okay.
And then finally, we can also provide services for people that are not able to really work well with the kind of traditional, pretty invasive exam that is a women's health exam. And we do provide exams that are under anesthesia, so that people can be comfortable, their anxiety levels can be reasonable, and those things work well. However, I would tell you that many people overestimate the need for these very disruptive, kind of takes a full day of your life to go have some very quick women's health exam. And I often try to explain to people that, for healthy people that are just getting screening, that this is a very quick exam. We can do it in a variety of different settings. A pap smear for this patient population often takes me about 10 seconds. And so it's not overly taxing for many patients, and many patients find that they're able to manage something that maybe they didn't think they could, or their caregiver didn't think they could. And that can be very empowering for all involved.
Absolutely. And I think it's important that you mentioned the caregiver there, because a lot of what we're talking about can be based on caregiver readiness or caregiver opinion on ability to go through something like this. And to your point, there are people that really can tolerate it much better than anticipated. As we mentioned, the caregivers, can that caregiver be in the room during an exam?
Absolutely. And generally, we would prefer it. If that caregiver is kind of appropriate for the interaction. For some of our folks that come from residential or community group homes, they may come with male caregivers sometimes. And so those caregivers usually want to stand outside the room. Sometimes they can stand behind the drape, if that works better. And then many of the other caregivers, we're happy for them to stand up kind of next to someone's shoulder, near their head, hold their hand, because we want to make these environments, comfortable. We have a variety of different ways of accommodating and making people comfortable with intellectual disabilities. And we have activity boards, objects to kind of help distract and engage people. We play a lot of music. The beauty of our phones now is it's like a jukebox of, I ask about everyone I see what kind of music they like. And if they tell us, Michael Jackson or Elvis or, Lord knows what people will tell me, I can pull it up on my phone and we can play whatever they want. So we aim to please.
That's awesome, because it can be those little things that really increase the comfort level and therefore the tolerance. Just quickly, for those that aren't able to tolerate it, you mentioned different ways of doing things. I do want to share the story of how I met you, and that was through another one of my speakers, Dr. Takelet, who provides dental care. But at the clinic, they also provide dental anesthesia. And I learned of a coordination that involved you and Dr. Van Dusen, who had also been a speaker of mine, that all three of you were able to provide your individual specialized care to one patient simply because you were able to coordinate that anesthesia.
Yes, when possible. It's not it's pretty tricky to get everyone on the same page for those sort of dental exams, because I know that those are hard to get as well. But we love to provide access and efficiency for patients and their families. I know that everyone spends a lot of time and energy helping, taking people to appointments, helping out, and especially the idea of basically an appointment for one thing. If you're like, man, I would love for this to happen for multiple different items at the same time. If possible, we would love to meet that. And certainly that's what everyone deserves. In the ideal setting, I wish we could group together several different things at the same time for people that need that, under anesthesia in all the circumstances.
Absolutely. It would be great if everyone could get one-stop shopping and it was all catered to the individual need. And sometimes you're able to do that, but just knowing that your center is out there, it is a huge benefit to women in the region. It also gives me hope, because we may have people watching this that are not from the region where you're located in Pittsburgh, But I think you mentioned that sometimes you are researching and coordinating with other hospitals. If someone is outside of this area, but here's something that like, that's what my loved one needs, what would you say to them?
Well, they're welcome to reach out to us and give our office a call. We do have some connections with other places and centers that are learning to do this. Sometimes we're honored to have people come from other locations in the country to kind of see how our clinic works. It's I think it's very accessible and people can do it other places. And so, for instance, there's a clinic starting up in the Washington D.C. area, and I know of one in Boston, and I can think of one in New York City, and there are times when like, well, in Philadelphia, I know of one in Delaware. There's a variety of different ways to kind of to move forward with it, but it's sometimes a challenging service. Now, I want to say the ideal circumstance would be that every woman can go to whatever office that they want to go and they'll receive accessible care. And I think there's a lot of great doctors that probably do a really, really good job at this. We love to specialize in it, but that's not the solution for everybody. And so ultimately, we do spend a lot of time also trying to educate other providers to realize that this is a manageable and important thing to provide for all people.
Absolutely. And I think for anybody that, is caring for a woman with a disability who hasn't really specialized in this, what we've heard from you is some of the things are quite simple. You mentioned the waiting room and just educating the staff to know how to communicate, what to anticipate. Those are huge strides right there that anyone can make at little to no cost, but just to consider that those might be things that need to be done. One of the other things that you and I had talked about, and you mentioned earlier, one of the things that you can allow for is longer appointments. But I know sometimes people consider that, okay, well, I have this appointment and my insurance will pay for me to go to the doctor one time, but one time isn't enough for me to get to know the doctor and be comfortable. To start with, we're doing this conversation face to face, and now you have to do something pretty invasive. So how do you handle those situations?
That's a great question. A lot of people think that when they come and visit me that I'm going to almost like demand to provide like the full physical exam as a part of the interaction. And there's a lot of people that I think meeting our team, seeing the location, and just talking about things can be, a very good first step. I do that. I might, counsel people about their periods or their body, or, talk about things to watch out for caregivers that, just may have not thought through. It's like, well, what should I be looking for? I can do a variety of counseling things and then do as much physical exam as may work. We might be able to do, a clinical breast exam, or I might be able to explain that for every individual breast cancer screening, by either ultrasound or mammogram is available to people. So, all my patients with intellectual disabilities are getting screened for breast cancer, and they might be getting it with an ultrasound, which is a lot more accessible for someone that may have a coexisting like cerebral palsy or other orthopedic change in their body. And so we're just trying to provide, education and kind of help people understand the lay of the land. And sometimes many times we won't do a physical exam at all. And I don't think of that as a loss at all. I usually think that that's exactly what people and the caregivers needed. And usually, as we said, like, thankfully, these things don't need to be done every year. And so I always say, well, you met us, and then if you'd like to come back next year, we can do this again or talk about other things we can do. And just know that we're not a hard sell. I don't think it works well to be a very pushy, overbearing gynecologist. I really try to aim on the very other end of being very easygoing and hopefully approachable.
And I think that's really crucial. And I hope that our audience is hearing that while it's important to get this care, what you just mentioned about you don't necessarily need an internal exam every year. So maybe you can work up to it. And you mentioned counseling. So it sounds like that is a way that insurance may pay for that visit and still pay for an internal exam when it's time to do that. Is that correct?
Exactly. So we might screen and we might talk about abnormal periods or do breast cancer screening, a physical exam alone. And then the next time we could do, that pap smear if that's where everyone's kind of comfortable at that point. So do not feel like this is like but usually we can get what we can get done. And I'm also comfortable, providing documentation for people that are in residential settings that need documentation to show the state that they're up to date on their, women's health screening, to say, listen, I did this. I recommend coming back next year. I think that we're in a fine place. We can wait a year for cervical cancer screening. So I understand the regulatory pressure that that many people are under to make sure that everyone's up to date with their women's healthcare, and just know that there's, I think, a wide variety of ways that we can do that. It's not just one way.
That's awesome. And I think that education is huge because we all need it every day. Just in the next few minutes, I don't want to run out of time, but one of the myths I'll just bring up, and please give the open, honest feedback, but I think there is this thought out there that women with disabilities should not have sex or should not get pregnant. And I'd like you to just speak a little bit about that.
So it's a challenging subject. If we were to divide it a little bit, first we could think about, intellectual disability. For people with mild intellectual disability, there's actually a rich set of resources to talk about bodies and sexuality and relationships and boundaries and safety that does exist out there, that feel like I'm in no way an expert in it, but there's great stuff out there that I'd be happy to share. And so thinking through that population, it's a tricky one, but there are people that it's appropriate to consider, relationships, including, physical contact. That said, there's an incredible variety of ways that can go and be coercive, abusive. The power dynamics can clearly be off for someone that's very vulnerable to coercion and abuse. And so intellectual disability, I would say that we want to be very, very careful. And I'm just very sensitive to a wide variety of ways that this can be harmful to my patients if not addressed in a very careful way. For people with mobility disabilities, it's really amazing how much messaging is sent to those people in a variety of ways. It might be a family member, a doctor, a friend. Think if someone never asks that person about whether they would like to have a family or how many kids they want to have, or if they want to be in a relationship. If someone never is related to that way, they basically assume that the world around them, including healthcare providers, doesn't want them to participate in being a parent and being pregnant and using that part of the life experience. And so these people will frequently go many, many years or decades without anyone addressing a basic question of, would you like to be a parent? Would you like to be pregnant? What are some concerns you have? And it's a great joy to address that question with people, regardless of what they say in response. So there are people that choose not to parent and they choose that, but they say in their 50s, I'm so glad that you asked me that question. No one ever asked me that question before. It's very empowering and inclusive and kind to someone. And then for other people, they say, well, oh, this is something that can happen in my life. And then that can be a very rewarding part about someone's life, to be encouraged to realize that there are safe and healthy ways to include pregnancy and parenting in their lives. And so it is a great joy to be optimistic and positive in an environment where people receive a lot of negative messages about something that is at least a consideration that everybody should be able to make on their own.
Absolutely. Well, and I very much appreciate you mentioning the inclusiveness and the empowerment brought about by simply having the conversation. And hopefully today's conversation is empowering for women and their caregivers to know that there are resources out there. Before we do run out of time, I'm going to share my screen so I can share the contact information to make sure that everyone knows about the clinic and how to get in touch. And while I'm bringing this up, if you can just tell us, where is the clinic located and how would someone begin the process?
So we are in Magee Women's Hospital in Oakland, in Pittsburgh, and we see people on Fridays. And if you contact this number, we will, sometimes you have to leave a message on that number, but a nurse that's experienced with scheduling people with a variety of different needs and accommodations will help make sure that we understand what people need, and also that hopefully the timing of the appointments works well. You know, we have many patients that need, say, a patient lift, and we want to make sure that we don't have many of those patients sort of in a similar period of time, because we only have one Hoyer lift in one room that works really well for that. So we try to be really accessible. We do offer telemedicine visits for people that maybe their caregiver just wants to talk over video with me. I'm happy to do that as well. And we look forward to offering those services. Also, it's not just me. There's a female provider, Julie Magee, who's great and provides that accessibility and diversity in providers that's super helpful and appreciated. And so we want to provide what people need, and in a way that's comfortable for them.
That's awesome. And for anyone that may have visual limitation that is not seeing this, that phone number is 412-641-4455. So I just want to thank Dr. Harris again for taking the time and sharing this really crucial information. And I hope as a result, we have really made a difference in women's lives. And then as a reminder, the next session will be on Wednesday, September 27th, at which time we will speak with Brandy Cooper from the Pennsylvania Tourette Syndrome Association. So thank you all for joining us today. And thank you so much, Dr. Harris, for sharing your knowledge and your efforts through this clinic for women with disabilities.